Thank you very much, and good morning. Can you hear that? How's that? Yeah. Okay. Thank you. It's a pleasure to be here. I was delighted to hear some of the last panel, and regret that I wasn't able to be with you this morning, but I very much appreciate what the New America Foundation is doing here this morning, and hope that they will continue to do this throughout the course of the upcoming year, really, because one of the problems right now in the area of health policy is that we always all know what we don't like, but what we do like is going to be, take some construction, the literal infrastructure for controlling costs in a way that preserves the quality of the development of healthcare. That is, its growth and development is really never been done in any country, anywhere in the world. So it is a new challenge that we're going to take on as a country. We're the ideal country to take it on because we're so inventive. And we have now as a society got it, but it's very important to pause and think why we're here, what we know, and where we're going. And I'm just going to kind of lay that out quickly because, of course, technology is fundamental to the solution. And it's technology of a different order in healthcare than we're accustomed to. So it's going to command a level of change of us that's going to affect every one of us. And probably the biggest danger that healthcare reform poses to us is that we will try to create the future in the image of the past at the very time the past has and is failing us. So let me just reiterate one thing that we tend to forget. We are at the point we're at because of the extraordinary advances in medical science. It's those advances that have created subspecialties and sub-subspecialties and new technology and new diagnostic treatments. You know, that's what makes American medicine remarkable, is that it's unrelenting movement forward. And of course, the government stokes that by putting more and more money into NIH funding. So we are getting what we pay for. We want medical science to advance. We want it to give us better health. And we are now confronted with how do we control the costs of a system that just pays for buying it off the shelf. Well, anything you want is of equal value, and insurance pays for it, or Medicare pays for it equally, whether you need it or not, whether you just had it or not, whether it's going to help you or not, and so on and so forth. So you have this incredible stocking of the shelves of health care actions and incredibly developed American consumer. I mean, more developed than at any other time in our history because of the dissemination of credit cards. And you combine the two, and you shouldn't be surprised at what you get as an extraordinarily costly system that doesn't deliver as much value as it ought to. So I just point that out, not because you don't know it, but because that tension between the extraordinary quality of American health care and our ability to afford it is profound and very deep. And all the polling shows that. So people want change, but not if it's going to affect their benefits. They want change, but not if it's going to cost a new tax cut. So we are really, the intensity behind the tension is greater than it's ever been, and we forget that at our peril. I did also just want to mention that as we move, the good news is that there's a good deal of agreement on where it is we have to go. The bad news is that there's not a lot of agreement on how we get there. Now, as to where we go, we all know we need to move from an illness treatment system to a health and wealth system. We'll never, ever be able to afford a healthcare system if we don't do a far better job, not a little bit better job, a dramatically better job of prevention, of wellness, of managing chronic illness. Because where do 80% of the dollars go? To the 20% of the people who have chronic illnesses, multi-chronic illnesses, whether it's in the elderly population or the younger population. So we have to focus on that, and we have to focus on what we're delivering to that group, and that's why this issue of bundled payments does make sense. It does focus on those who are sickest because they're the ones that got in the hospital, and helps us watch to be sure that whatever we did for them in the hospital actually pays off and has some value. But it is only the first step. If you're going to go from paying for value to paying for quality, you do have to begin to think about the continuity of quality. Now, we've done some remarkable work in the area of quality. We know how to measure a lot of things we didn't know how to measure, but it's primitive. I mean, remember that. When we talk about quality, we know how to measure whether or not a heart attack victim gets a certain shot when they come to the emergency room. But how much do we really know about measuring the quality of a care process? And if you define the quality of the care process, and this is what we're in the process of doing, I'm pointing it out. If you try to define the process of the care, the quality of the care process in the particular way we have described reimbursement rates to date, then you will just create an ever more complicated and paralyzed system. We have to do in healthcare what we did in welfare reform. Instead of saying, this is what you have to do, this is the way you set the rates, these are the things you have to do if someone's on welfare. So we just want to know how many go to work. Do it yourself. How much goes to daycare? How much goes to job training? How much goes to stipend? How do you mix those three things? I'm not saying it's perfect. What I'm reminding you of is that it was a whole new way of legislating. It was the first time we ever just began to say, let's look at the outcome and let the states do it. Now, if you think you can do welfare reform with HIT or no HIT, either way, health reform, you can't do healthcare reform unless you begin to pull the government back so that the government just pays for value and for outcomes. Because if you don't do that, then you're going to incentivize the whole system to select the healthier people. Because guess what? The treatment will come out better on the quality space. The patients will do better on the quality measures. And you prejudice the whole system against the people who need it most. So one of the things we're not giving enough thought to, although the experts are beginning to really think seriously about how do you measure what the quality of a process. Actually, there's been a lot of thinking on this. I wouldn't say we're where we need to be, but we'll learn a lot from the bundling issues. Part of this is that we have to move forward even though we don't have all the knowledge we need. So as we move forward into bundling, into medical home payments, into gain sharing payments, into these accountable care organizations, which are interesting because they're not unlike the medical home, but they build on the referral structures that are already established, the relationships that are already there. And you could build that system in such a way so that it is patient-centered. What is this patient's referral structure? What is that patient's referral structure? And I mention that because if you're going to measure outcomes and you want to get to medical structure in the 21st century, you better be able to look patient-centered. Otherwise, you will destroy the opportunity that America has now and that Americans have come to expect of a healthcare system that serves your own healthcare needs. I mean, just look at the importance of a physician being able to order genetic tests if a person has breast cancer or psychotic issues. You can tell from the genetic test which medicines are not going to work, and you can tell which ones are more likely to work. And it's going to become irresponsible to determine a treatment modality in certain mental health areas and in certain other areas, and this will happen more and more rapidly. And instead of saying, Mother, may I, will you cover this genetic test for this particular patient and have to prove that this particular patient has this array of illnesses and therefore is going to benefit, can't do that, see. You're not going to be able to run a national health care system that's affordable and that covers everyone and delivers the care they need and keeps them out of the high-cost settings if you have to do that. So as we move through and develop bundling mechanisms and things like that, we have to pull the government back. We're going to have to repeal law. We're going to have to get started a little bit out of it. I mean, I'm seeing home health agencies doing absolutely phenomenal things to keep people out of hospitals by maintaining relationships. There's one out there that focuses, there's probably more, I just happen to know this one, that focuses on behavioral change during the episode of care. then they support the patient in maintaining behavioral change. Well, that's what you have to do if you want health and wellness. You have to teach people to preserve health, to manage wellness, to get there, see? And they can actually document how much money they have saved by keeping people out of hospitals and emergency rooms. But guess what? Somebody said, don't you realize you're illegal? If you follow a patient more than 6 months without charge, you are now illegal. So, you know, that's not what we want. So one of the things that worries me the most, I would say, is that too little thought is being given to what are we going to need to repeal. Don't just let it layer another layer over. You have to repeal. One of the best things about the Obama budget is that it raises the doctor's threshold and pays off all that artificial, irrational wave of debt that we owe under the current physician payment law, so that Congress can pay only for whatever it's going to cost to pay physicians some increase next year based on performance or whatever the government decides or whatever the legislature decides. But at least it gets rid of the irrational barrier to reform and to progressive change. So there's just lots of examples out there, and I was interested in the earlier panel talking about technology. Don't worry about technology, worry about us, worry about government. Don't let government put barriers in the way. Now, I'm a big advocate for the HIT provisions in the stimulus bill, but if you look at them carefully, they were framed with what we knew 5 years ago. And so they're framed primarily with the focus of funding electronic health records in physician offices and readers. And guess what? If you haven't seen this, you need to see this. January 9th, a report came out from the National Research Council, commissioned by the National Institute of Medicine, that said this won't work. And it won't. So there is technology out there. I'm personally aware of a technology that's been piloted now for 2 years a day. It has already saved the employer and the plan so much money that they give it to the docs. The docs who weren't a part of their plan, but have a patient who's in that plan and therefore have seen this, came to them and asked them, can we use this? And they said, sure, it costs $4,000. You know, in the end, it doesn't cost at all because it saves so much. The plan and the employer easily split that, and they easily split the fees because it did exactly, I mean, in 2 years it's shown this. Now, it still needs to be piloted, but it tells you there are other ideas out there like this. In 2 years, it has not only demonstrated that a little stripped out, that it attracted, first of all, it attracted the patients in the employer's base that had multiple chronic illnesses. And it stripped out all the duplication, you know, all the administrative waste and all that stuff that we all talk about. And it's so big, nobody realized how big it was. The plan did and the employer didn't. It's big, big, big bucks. So it stripped that out. But then it shows from their data that the people who chose to be in this plan did go to doctors more, did do all those things we want them to do that are lower cost, and did use the emergency room in the hospital less. So, and the spread was significant. So don't believe that America's inventiveness isn't going to help us out of this. We just have to be sure to push it. I was fascinated in the comment about standards. Absolutely true. Standards aren't a problem anymore. The standards are out there. The problem is they're low. So we have people calling us and saying, well, what's meaningful use? Do you think our technology will pass meaningful use? Well, it depends on how they write meaningful use. But in terms of the law that was just passed, yes, existing technology will do it. And yes, existing technology is not interoperable. So yes, I mean, it's really sort of phenomenal that in order to get everybody on board, you know, the language was written in a way that nobody felt threatened. On the other hand, if the regulations don't crack down on meaningful use pretty progressively, you won't incentivize institutions that may be pretty good at internal communication at now being able to communicate with others outside. Because we've done a really remarkable job intra-institution. You know, Kaiser, big hospitals, there's lots of examples. Marshfield, Intermountain, there's lots of examples. Kaiser, you know. Our problem is that we can't hook up systems. We have more problems than that, but I mean, the biggest ones is that. And what's interesting about this technology that I happen to be familiar with is it's entirely patient-centered. The patient owns it. So the question from an earlier speaker about, do I carry my little chip? You can do that, but you can also, you empower your doctor to see it. You can empower your favorite daughter to see it, not the one that's a pain in the neck. So you control access, you can see access on everything, it's completely accountable. But what's most exciting about it is this patient-centeredness, because it was through the patient-centeredness and the simplicity of the communications that they have on the patient site. There's one sort of 4th grade level group and one sort of 8th grade level group, but it's the same information your doctor has. So there's a motivation to see it because your doctor's seeing it, and you want to see what he saw from the latest test. But then there's a motivation to turn red lights green. And that has proved to be a very powerful compliance. I mention it because if we don't get the patient involved, find FHMT. Actually, remember years ago, WellPoint gave everybody from like a personal record, millions of people, 25 million, I think. They don't use it. See? So it isn't just having it. It's like it isn't just having an electronic record in the doctor's office. It's whether we use it, how we use it, and does it change our thinking. So I really like Craig Barrett's description, ubiquitous continuity. And this is going to change the delivery system in medicine far more than we're recognizing. And that's why the payment systems and the law must not stand in the way of that evolution. It just must make it accountable for quality care, accountable for patient-centeredness, accountable for connectivity. And if we do that right, then we will see develop what we absolutely need and must develop, which is a more patient-centered, preventive, wellness-supportive care system. So it is an exciting time for us, but it's also a dangerous time when you look at that report that came out on the 9th, and now will we do it right? Another real danger, another big danger is this issue of a public plan. And I'll tell you why that's a danger. It's not a danger because I'm a Republican. It's a danger because the current system is failing us. Got it? That means that the current plans are also failing us. Too many people can't get their health care because of the 20% copayment. Their employers are doing everything they can. But the 20% copayment of something expensive is a lot. Well, acquaint yourself with the value-based insurance design movement out of the center of the University of Michigan, because big employers now are doing things like, you're diagnosed with diabetes, you get your medicine free, as long as you take it. See, if we don't build personal responsibility into the new system, if we don't remotivate patients as well as remotivating providers, we will fail, because we'll fail by the use test. And if you don't use it, it will save the money we need to save in order to cover everybody. And that is our goal. But we have to be able to deliver just the care a person needs in order to be able to afford a universal system. So don't think this is just about fixing the public programs or tweaking the private programs. It is about changing the structure of private health insurance to motivate patients just as much as it's about changing the structure of payment systems to motivate providers. Both have to be motivated to participate, to be on the team, and to be looking for efficient, high quality, and effective care. If you do that, you come to the end of the track and you develop cute communities like the slow aging community in New Hampshire. The slow aging community is a group of over 65ers who have banded together, and they demand a different level of information from their physician team. They want to know not only what you could do for me, but what will be the consequences, what are the alternatives, so that they can begin to make more personal choices about how much pain, how much cost, how much compromised quality of life, versus letting nature take its course. We don't like to talk about end of life, but frankly, we have to talk about end of life, partly because so much money is spent at the end of life. But you see, if you have a system in which people have become involved in their health and wellness, that as they get a complicated disease and one treatment slows down or doesn't work like it did last year, then you go to the next one. That one doesn't work like it did last year. So they begin to figure out and to see themselves that their body is going a different direction, that they are aging, and that the cost of prolonging life is ever greater for them. Now, in the end, I would rather have a system. This is why I'm so keen on technology, on patient-centeredness. In the end, I want a system in which we each have the right to say, I want everything and I'll pay a little extra. Instead of the system that is common in Europe and that some would advocate here, where the government puts in place a board that says, this benefit is too expensive, we're not going to let it be part of the system. You really have your choices, and we have to do something about end-of-life care and about the extraordinary investment we make in almost hopeless situations. So you can either do that by bringing people up to value life, and to take part in their health and wellness, or you can do it through the arbitrary mechanisms like England. I mean, in England for many, many years, and it's still more or less true, it's easier to get around now. If you're at 55, you don't qualify for dialysis. Saves a hell of a lot of money to a personal language. Not a government regulation I would want in America. So it is very important to recognize that we can either grow and develop through technology and enlightened approach a system that governs everybody of every age, that gives us the power to deliver the right care at the right time. Or we can control costs primarily from the outside through arbitrary caps. I mean, it's even being mentioned in Massachusetts now, that they're going now to a new round of coordinated care, very interesting payment, trying a flat payment with a bonus. Now, their flat payment will be adjusted for age, gender, and severity. I don't know that the federal government can do that for every seniors all across America. That gets to be quite awesome. But we do need to see how it works, and the bundled payment systems will give us that kind of information in our own system. But in the long run, you really don't want outside forces limiting care, but you will have to have outside forces that say, just as we do today in Medicare, in Medicare we do say now if you earn more, you pay higher premiums. Now, I got that provision in the Medicare Modernization Act, and I have to tell you, I pay $300 a month for me, and the average senior pays $100. So if you don't think that these things don't bring in money, they do. But you want a system in the end where you do have choices, and everyone has the same choices, but if your choice that you want to make has very little likelihood of improving your health, then you are going to have to take more responsibility for cost. Whether we acknowledge that now, or we let it happen to us later, whether we get it done to us or we do it to ourselves, in the end, that has to be one of the things on the table. So this is a very exciting time for us. It's very, very hopeful in my estimation. There's so many things we could do that will be really helpful right now. We just have to avoid critical mistakes and begin fostering the kinds of discussions that we've had here today, educating up the Hill and the administration about the level of dynamic development in the private sector that's out there ready to do a lot more than they've been asked to do. So with that, thanks for being here today, and thanks very much to the New American Foundation for inviting me to participate. I'd be happy to take some questions.